Welcome back as we take a look at the concluding portion of our blood vessels. We'll continue on where we left off, talking about control of blood pressure. And here we'll begin to look into increasing blood pressure. We have some different hormonal components as far as our blood pressure goes, and things that we can utilize to increase blood pressure, decrease blood pressure, depending upon the particular situation that's there. And so some of these we talked about back in the endocrine system, and as far as uh, hormones go, and so things like the adrenal gland producing epinephrine. This is going to have a net effect to increase the blood pressure on the body. So when we're in a fight or flight situation, sympathetic nervous system is in. We're going to also have our stress hormones being released to help out to increase blood pressure. From there, if blood pressure is low, we have the ability to alter the amount of blood volume that we have. And so one of the ways that we can do that is through antidiuretic hormone, or ADH. We talked about that one under the endocrine system. In addition to its ability to conserve water in the kidneys, it's also going to cause vasoconstriction. So it's going to cause the blood vessels to start to vasoconstrict and increase blood pressure in that way. Next up, we have angiotensin 2, and so this is part of our renin-angiotensin system. And so the kidneys, in response to a decrease in blood pressure coming into them, will release the hormone renin, and that renin then follows a cascade of reactions as an enzyme, and we end up with the release or the production of angiotensin 2. And once again, this one's going to cause vasoconstriction. So we get another vasoconstrictor coming out, allowing for an increase in blood pressure. Next up, the blood vessels themselves. And so especially when we have a situation where a blood vessel has been damaged, we have the ability to release our endothelin and prostaglandin-derived growth factors, or PDGF, both of which are going to be a vasoconstrictor as well. So we can decrease blood flow into an area that has been damaged. If our blood pressure has gone up too high, and so this is probably the more common one in most people at times, the heart itself is monitoring that blood pressure, and it has the ability to release ANP, atrial natriuretic peptide. This is going to decrease the amount of sodium reabsorption, and so we're going to decrease blood volume once again. So where the sodium goes, the water is going to follow, so we're going to lose the sodium, and so we're going to lose the water at the same time. Locally in different areas, we have things like nitric oxide. So nitric oxide has the ability to cause vasodilation locally in an area. Again, this is oftentimes going to be in response to some sort of local issue that is going on in the blood vessels themselves, or locally in the tissue. And this is going to add to our increased blood flow into the area, an increase in the vessel diameter. From there, we have inflammatory chemicals. We've seen potentially the effects of things like histamine. And so when we have an allergic reaction type of a problem, we get the release of histamine, and that causes potentially the redness on the skin, things like that. Prostacyclins, kinins, all are going to have that same effect to cause vasodilation. From there, we have another kind of outside process that can occur, in that alcohol has the ability to inhibit ADH. And so this is going to, as we inhibit that ADH, this is going to increase water loss and thereby decrease the amount of fluid that we have available for blood pressure itself. And so another way that this process kind of continues on as well. Most of the time when we talk about the ability to control things long term, we're going to be talking about the kidneys. And so long-term mechanisms themselves are generally going to look at our ability to control blood volume. And so either get rid of more water or keep more water, depending upon whether we want to lower blood pressure or raise blood pressure. And so this is where we'll come back to this and circle back to this again at a time when we talk about the urinary system as well. But one of the things that the kidneys do is, in a sense, the kidneys are kind of self-serving. They're going to always want to be able to maintain their ability to filter the blood itself. And so we have a change in, or when we have a change in blood pressure that's affecting the kidneys themselves, over time, they do have a bit of an adaptation response to them. And so when this does occur, this allows for the kidneys themselves to attempt, if the blood pressure is too high, to eliminate more water. And so try and get rid of more of the water through the kidneys themselves, lose it out of through the urine. If the pressure is too low over a period of time, then that decrease in baroreceptor activity is going to lead to the kidneys retaining more of the water as well, and thereby raising blood pressure. So the kidneys have the ability to essentially act both within themselves as well as outside of themselves. And we talked about part of it before in terms of their production of the hormone renin. And so the renin-angiotensin mechanism has the ability to work essentially outside of the kidneys. That's there. But the kidneys also have the ability to control blood volume from within. And so they can do their vasoconstriction, they can do their ability to lose water or retain water in order to maintain blood pressure as well. So if the kidneys are functioning normally and everything is going well with them, and they sense that we have a declining blood pressure, so blood pressure drops, that's going to cause the kidneys to release renin. Renin is then going to activate angiotensin 1. Angiotensin 1 is going to then be converted into angiotensin 2, and that angiotensin 2 is now our vasoconstrictor. Angiotensin 2 is also going to work as a hormone to increase the release of aldosterone. And so both of them are going to then increase the ability to reabsorb water. And so as blood pressure is falling, the kidneys are working from the inside, in a sense, releasing renin. That leads us to our angiotensin 2. Angiotensin 2 stimulates the release of aldosterone. Aldosterone then is going to increase absorption in the kidneys. So it's going to increase water. It's going to increase sodium, and thereby increase blood pressure. And so ADH causes that reabsorption of water in the kidneys, thereby causing blood pressure to start to go up. And so we have this cascade effect of where the kidneys themselves are helping to help themselves have a higher blood pressure, and at the same time raising blood pressure for the rest of the body as well. When we look at the cardiovascular system, and so when you say whether your cardiovascular system is functioning normally, essentially the ways that we have to monitor this are when you go to the doctors, they take your vitals. And so the vitals themselves include things like your heart rate, so your pulse, they take your pulse. They're going to take your blood pressure, they're going to take your temperature, and then they're going to take your respiratory rate. And so they're going to look at all of those and determine, in a sense, how well potentially the cardiovascular system itself is functioning once it's there. And so this allows us to determine on at least a bit of a scale how well potentially the cardiovascular system is functioning. The pulses themselves may then also even be taken regionally or locally in different areas of the body to determine that normal blood flow is occurring into those particular areas of the body as well, and make sure that things are happening the way they're supposed to, in a sense. And so kind of in your routine doctor's office visit, it's the radial pulse where they're going to take a pulse. If they can't find a radial pulse, they may look to a brachial pulse, especially in something like an infant even. May rather use the radial pulse or even the femoral pulse, or go down to the knee and take a popliteal pulse. Essentially, anywhere we have access to an artery, we have that ability to take a pulse there. So pulse is relatively, and heart rate is relatively easy to get to. Blood pressure is going to require a little bit something extra. And for blood pressure, we're going to look to the sphygmomanometer. And the sphygmomanometer is going to allow us to occlude the blood moving through a particular area of the body. And as it does so, we can then measure when that occlusion then decreases. And so I'm going to go to the picture here on the next slide here and talk about some of the stuff that was on those last couple slides. So here we have the brachial artery. And so we're taking the measurement in a sense at that brachial artery. And we put the blood pressure cuff on there. So our sphygmomanometer goes on around the arm. It's going to squeeze and squeeze and squeeze the arm until, and as we're doing so, we're raising the pressure inside that cuff. And that pressure is going to increase and increase until we cut off blood supply. So if we were monitoring down here at a pulse, in the radial pulse, we would find that it is pulseless. There's no pulse there. We happen to be measuring it with a stethoscope right up here, and again, there's no pulse. There's no blood flowing through those vessels, and so we've occluded that blood flow. Now, after we've taken that blood pressure up, and so if this is our dial here, and I'm never going to get it up there high enough, 50, 60, 70, 80, 90, 100, 110, on there. Our dial is now pointing above 110, and we can start releasing the pressure. And so we can start releasing the pressure in the cuff itself, and we eventually hear a sound. That first sound is what we call a Korotkoff sound. And so that Korotkoff sound is the turbulent blood flow as it's going through that compressed blood vessel. And so it makes a sound. The easiest way to kind of think about this is if we had a hose and we were listening to the hose, in a sense, kind of flowing water out of it. As the water comes out of the end of that hose, it doesn't really make any noise. But if we squeeze that hose just a little bit at the end and allow the water to come out, it starts to make a bit of a sound, kind of a whooshing sound in a sense at the end of that hose that we can hear. And that's the equivalent, because now we have turbulent flow. The same thing is happening inside our blood vessel there. And so we can now hear that. And so we're going to hear this foom, foom, kind of a sound inside there. And that's going to continue to occur from the point where we first heard the sound, which was right here, to the point where we no longer hear any sounds, which is going to be this point here. Once we get to that point where there's no sound, it's because the blood is flowing without any kind of obstruction. There's no pressure, nothing pushing on that blood vessel itself at all. And so we get laminar flow. The blood is just simply flowing through, and there's no turbulence inside. Those 2 points, where we first heard the sound and where we stop hearing the sound, is our blood pressure. So in this particular example here, we heard the sound at 110, and we stopped hearing the sound at 70. And so their blood pressure is 110 over 70 on there. And so with that, we have the ability to now see what kind of pressure is their body having to generate in order to create enough flow through their body itself. And then we can look at things like what's our pulse pressure. So our pulse pressure is 40 in there. And then we can take our mean arterial pressure and so on and calculate those also. And so those can then be calculated from there. And we can get a good idea for how the cardiovascular system is working as far as the heart is having to push that blood through the system itself. on there. And so we listen for those two separate sounds as we deflate the cuff and have it moving out. As we look at that blood pressure, we're looking to see whether the person has quote unquote normal blood pressure. And if their systolic pressure is consistently below 100 millimeters of mercury, and so if they're something like a 90/60 or something like that, we're going to say that they have hypotension. And so they're not necessarily being able to perfuse their body enough with blood flow so that they have normal perfusion within their cells everywhere within the body. If their blood pressure is, again, consistently elevated and they have a consistent blood pressure that is over 140 or over 90 or higher, then we're going to have a situation where the person is hypertensive. Typically, we look at this as being 3 separate visits, 3 different times, also possibly having the patient do it at home, so that we make sure that there's nothing causing any kind of elevation in pressure, because things like emotional components can raise blood pressure. If they're nervous, they think they have high blood pressure, they don't want to have high blood pressure, they don't like going to the doctor, all of those things can elevate one's blood pressure for them. And so all of that can play a role in terms of their overall pressure that's there. And so we need to be able to measure it at different times and different situations and things like that. If it is truly hypertensive and it's more chronic related, then we start to look at cardiovascular issues, whether it be the heart or the blood vessels that are potentially there causing the problems themselves. Because we want to make sure that we're not going to have something like heart failure, have potentially throw a clot somewhere and have a stroke or have a heart attack. Those kinds of issues go along with hypertension and even kidney disease. On the hypotensive side of things, sometimes people have what's referred to as orthostatic hypotension. And this is essentially where your body is the culprit, so to speak. And so you go from sitting to standing, you go from laying down to standing up, and all of a sudden you get lightheaded. And it may actually cause you to pass out. It may not. So you may have a syncopal episode there. You may not. Maybe you just sit back down and it all goes away for you. In other people, they can have chronic hypotension. This can be signs of poor nutrition, signs of, in terms of the body, not having enough nutrition that's there. We can have issues in terms of endocrine disorders like Addison's disease, and so we're having problems with the adrenal glands and production of hormones there as well. Acute hypotension is typically going to be in the form of some sort of shock. And so somewhere along the line, the person is losing blood. And so they're potentially losing that blood because of an incident, or they're losing it because they were potentially post-surgical and something is no longer not bleeding that was there. Hypertension as well can be transient. We can see it from time to time. Some of the things that we mentioned before as far as those components go. There are risk factors that kind of go along with both primary hypertension as well as secondary hypertension. With primary hypertension, essentially, the majority of the things are things that we don't have the ability to necessarily get rid of so much, as far as the driving forces that are there, especially things like age, race, genetics, and potentially stress. Other things are definitely more things that we can control, things like diet, obesity, smoking, more behavioral types of issues that can have that effect to reduce the potential for hypertension. Secondary hypertension things are things that are coming from, in a sense, outside of the, potentially outside of the cardiovascular system itself. And so something like a kidney tumor that is producing too much renin, assorted endocrine disorders, things like our Addison's disease we just said can have an effect on there as well. Inside the blood vessels, but caused by an outside factor, we can have things like arteriosclerosis. If we can fix those particular problems, then we can potentially get rid of the hypertension as well. Within a particular region of the body, any kind of organ system, flow to that area is going to be controlled on a couple of different levels. And so we have autoregulation, and this is essentially matching the needs of the organ to the blood flow into it. And so this is where if we're using an organ, so you get up, you start to walk or run, something like that, the muscles in your legs are going to get an increase in blood flow to them because they need it. They have an increased requirement at that time. In terms of that, we have basically the control there is going to be local. And so it's the arterioles that are supplying that blood supply to the organ in the organ system that's going to control that ability to either vasodilate or vasoconstrict and control the blood flow into that particular organ itself. Typically, when we look at the blood flow into a particular organ or an organ system, things like that, if one goes up, typically somewhere else something is going down. And so our pressure is going to essentially become altered in one area. It's going to be affected someplace else in the body, so that our mean arterial pressure, the MAP, remains basically constant. The demands of the local areas in one place of the body don't really affect elsewhere in the body itself, because we have essentially a decrease in flow that's going to be needed at that point as well. Metabolic needs in a particular area can increase the local blood flow as well. And so again, this goes along with the same lines of that of our metabolism in a particular organ or organ system that's there. And so looking at oxygen levels, looking at nutrient levels in the area are going to then allow for us to either vasoconstrict or vasodilate as well in a particular area. As we have nutrients being used up in the area, that's going to stimulate our autoregulation to increase blood flow into the area. So hemoglobin is one of the ways that we are going to get the oxygen into that area. Those hemoglobin molecules can also deliver nitric oxide. We said before that nitric oxide was a brief vasodilator, and so this can increase the blood flow into the area momentarily and increase the amount of blood flow and increase oxygen levels at that particular level itself. Other things can have an effect on it. Again, things like muscles, if we're using them locally a lot, we may have a buildup of lactic acid locally in that area, and that's going to increase our blood flow as well. We can have a decrease in pH, and so we have an increase in hydrogen ion concentrations in the area. That can have an effect on causing our increased flow into the area. Things like allergies, our histamines can have that same effect as well. Immune responses, things like prostaglandins and kinins, we have that same potential there as well, where we're going to increase that flow locally into that particular area. When we have inadequate blood perfusion into a particular area, we're going to allow for the smooth muscle to become altered in order to make sure that we have enough blood flow into that particular area. And so if we should happen to decrease blood flow into an area for any period of time, we're going to increase that blood flow afterwards. And so the blood vessels, the smooth muscle inside the blood vessels is going to either cause a vasoconstriction or a vasodilation based upon what is happening within the blood vessels themselves. And so how much oxygen, how much delivery is needed in those areas. So if we stretch out a blood vessel, and so we have an increase in that tone that's there of the blood vessel itself, in other words, increased blood pressure, the muscle is going to, in a sense, rebound and cause vasoconstriction. So it's going to try and fight against that increasing pressure that's there. And the same thing goes for a reduced stretch. And so as blood pressure falls, this is going to provide for an increase in flow into the tissues themselves. If we block blood flow into a particular area, we can end up with what we call a reactive hyperemia. And so a reactive hyperemia is similar to when you say cross your legs for a while and have one leg crossed over the other, and then you take it off and your skin becomes red. And so initially the skin was whitened. You have that little patch in a sense on the skin itself. And then immediately afterwards, it starts to become infiltrated by increased blood flow because of that ischemic event. And so we had decreased blood flow into that area. And now we have increased CO2 levels, increased acids in the area, lowered pH. All of that is going to then lead to this reactive hyperemia to bring in blood flow into that area once the blockage has been released. So it's going to be going from, in a sense, a blanched appearance into a bright red appearance afterwards. So many different controls for our blood pressure itself and our blood flow that is occurring. Many of them are metabolic controls within the tissues themselves that are going to create a auto-regulation scenario. And so those metabolic things being like pH, oxygen levels, CO2 levels, potassium levels. We talked about our nitric oxide levels themselves. And this is going to either increase or decrease flow into that area. So if we're using up all of the oxygen in the area and we're left with a whole bunch of CO2, we're going to increase blood flow. If we've got plenty of oxygen around, the tissue is not really working very much, we can lower that blood flow into that area. The out of the blood vessel controls comes from the nervous system. So we have sympathetic nervous system, either increasing or decreasing tone of the sympathetics is going to lead to a vasoconstriction or vasodilation, depending upon which way we went on there. We have our stress hormones that can be released, and so our epinephrine, norepinephrine. This is either going to cause vasodilation or vasoconstriction, depending upon where we are. From there, we have things like the components that are there for maintaining blood pressure, our angiotensin, our antidiuretic hormone, and our atrionatriuretic peptide on those. And that's going to alter our blood pressure and our blood flow locally into those areas also. The blood vessels can be used to regulate body temperature. And so as blood pressure rises, or as blood temperature rises, whether that be because it's just hot outside, whether it's because we have a fever or we've been doing exercise, this is going to trigger a response to bring blood flow from the core of the body out to the surface, so out to the skin itself. And so as that does so, as we bring that blood up towards the surface, our heat is going to leave the body as it radiates from the skin itself. And so that's going to increase there. The hypothalamus, being the thermostat of our body, is going to trigger then this vasomotor stimulation to allow for vasodilation up into the skin itself. At the skin, we learned when we talked about the integumentary system that we produce sweat. That sweat then is produced, and that's going to stimulate the release of water onto the surface. As it evaporates, our temperature then starts to fall, simply because we're now evaporating that water out and the heat of the water goes with it. If body temperature drops, or if it drops in different areas of the body, we're going to vasoconstrict, and blood is going to get shunted towards the deeper, more vital organs that we have of the body. When things start to go wrong with the cardiovascular system, one of the things that we can end up with is shock. And shock can then occur in a couple of different varieties in terms of what's the cause of it. But essentially what it comes down to is the blood vessels aren't able to get the blood to the tissues in a normal fashion. So we don't have a good enough blood flow to meet the demands of all of our tissues. And we'll talk about a few different types here. Hypovolemic shock. This, as the name implies, hypo, less volume. Essentially, this is blood loss. And so we've got some sort of blood loss that is occurring, whether it's trauma, surgery, things like that. Some way we've got to replace the amount of fluids that are there in order to retain any kind of ability to pump. We have vascular shock. In vascular shock, this is the result of vasodilation. And this is an extreme vasodilation. Essentially, all of the blood vessels have just simply vasodilated, and there's no ability to generate any kind of pressure. This can oftentimes come from a more common form in terms of anaphylactic shock. And so anaphylaxis, some sort of reaction to some sort of thing that we've been exposed to, brain injury, blood infection, sepsis, can all lead to a vascular shock. The heart can be the culprit, and we get our cardiogenic shock. Cardiogenic shock is where the heart is no longer pumping enough to, again, sustain the body's normal circulation that's there. And so this could be due to congestive heart failure, could be a valve issue, all kinds of any reason where the heart is the problem itself. We can also have an obstructive shock. Something like a blood clot may cause a obstructive type of a shock where blood flow is no longer adequate to a major part of the body, or potentially return back to the heart is restricted because there is something blocking that flow back to the body itself, or back to the heart itself. So many different processes can come along when we do have a hypovolemic type of a situation. So if we cut ourselves and we're bleeding, we're going to do everything we can to conserve water. And so everything's going to happen in a process of attempting to restore blood volume within the body itself, thereby doing things like decreasing urine output, thereby increasing blood volume, working on the heart to cause the heart to become increased heart rate, increased contractility of the heart, increase its ability to contract, and thereby potentially raise blood pressure itself. And so all the different processes that we talked about before, get our renin-angiotensin system going, get aldosterone going, get epinephrine going, all of that is going to help with the process of bringing things back around. When it comes to the blood vessels themselves, we've talked about a little bit when we talked about the heart, the fact that we have a pulmonary circulation and we have a systemic circulation. And so the pulmonary circulation is going from the right side of the heart out to the lungs and back to the left side of the heart. Whereas the systemic circulation is going to leave the left side of the heart, go out to the entire body, and then come back to the right side of the heart. And so we have two different regions in a sense where blood flow needs to occur in order for normal perfusion to occur throughout the body itself. Just a quick little recap of the blood vessels themselves. Arteries, blood is moving away from the heart, and so it's moving potentially out to the systemic circulation itself as it goes there. Arteries tend to be deeper in the body in terms of where we find them. They're not as superficial as veins. The arteries tend to have pretty good maps as far as where they're going to be found or where we can find them in terms of where they go. And they're going to supply the different organs and things like that as they go. Veins tend to be more superficial. We have both superficial and deep blood vessels within them. Veins are returning blood back to the heart either through the vena cava or from the that of the pulmonary veins and getting them back through there. Veins tend to spread. They have more anastomoses within them, and they can expand at different times as well. Developmentally, the blood vessels themselves begin to develop at the same time as that of the heart. And so we talked before about the blood islands generating our initial vascular tubes. And so we start out with essentially just a couple of blood vessels that are connected together, and this is going to start to pump the blood at the end of the first month. By that 5th week, the heart starts to develop, and once it develops, we're going to need to have some bypasses or fetal shunts that are going to change the flow of the blood away from areas where we don't necessarily need to have that blood flow occurring, simply because we're a fetus at that time. And so things like the lungs, the liver, don't need to get a tremendous amount of blood supply in the normal fashion that we have. And so we have different fetal shunts that occur. Here we have the development of our primitive or rudimentary blood vessels going from the blood islands down into the blood vessels themselves, and then eventually turning into the heart. Once we have the heart, we have one of our first shunts that we have in terms of blood flow is the ductus venosus. That ductus venosus bypasses through the liver, so hopefully everything coming in from mom is, in a sense, already taken care of. We don't really have to process anything as it comes into the body, and so we can get rid of that blood flow through the liver itself. After birth, that ductus venosus is going to turn into a ligament. That ligament connects back out to the umbilicus, and this becomes the ligamentum teres that's there. In the heart, we talked about the bypasses of blood flow as well, and so we talked about our foraminal valve there, and we talked about the ductus arteriosus becoming the ligamentum arteriosum, and then the fossa ovalis as well after birth around the heart as well. The umbilical arteries and veins are also going to, after birth, here we go, arteries and veins are going to turn into ligaments also, and those are going to then decrease their supply shortly thereafter birth and become to remnants after birth as well. So before birth, there's a lot more, in a sense, kind of purple blood, mixture of deoxygenated and oxygenated blood throughout the entire system. And in the born, after birth, or throughout the rest of life, we're going to want to have nice, in a sense, separation of oxygenated from deoxygenated blood throughout the entire body itself. And with that, we'll finish up our blood vessels.